Welcome to your shortcut to the latest in cardiology research. I'm one of your hosts, guiding this discussion under the supervision of Dr. Caroli from drcaroli.com.
Today, we're really getting into a fascinating review from the European Heart Journal.
We are indeed. It tackles atherosclerosis, but, from an angle that might surprise you. It looks at why it seems to show up so differently in various arteries.
Exactly. Think coronaries versus carotids, or say femoral arteries versus the aorta. Why aren't they all the same?
This isn't just a minor variation either, is it? The paper digs into really basic differences, how plaques form, what they're actually made of.
And the specific inflammatory signals driving things in each location. It really pushes back against viewing atherosclerosis as like one single disease process everywhere.
And for you listening, particularly cardiologists trying to stay current, this is, well, it's pretty important stuff. This review pulls together evidence suggesting that our usual risk factors, smoking, diabetes, hypertension,
Yeah, they don't hit evenly. It seems smoking, for example, has a real preference for the abdominal aorta.
while diabetes seems to disproportionately affect the lower limbs.
Right. And hypertension often links more strongly to coronary and carotid problems. So right away you see it's not a uniform picture.
It's not one size fits all at all.
And the differences get even more pronounced when you look closely at the plaques themselves. The review highlights, for instance, that atherosclerosis in the superficial femoral artery.
Down in the leg.
Yeah, it often progresses more slowly. And the plaques look different.
Typically.
More calcification, more bony structure almost, and actually less cholesterol compared to what we see in coronary or carotid arteries.
Which strongly suggests, doesn't it, that the underlying mechanisms must be distinct in these different vascular beds.
Absolutely. It makes you wonder if we should almost think of them as related but separate conditions happening in different places. Well, first off, the review points out a bit of a problem. There's a real scarcity of good comparative studies. So generalizing is tricky, but some patterns do emerge from the data we do have. Carotid lesions, for example, they seem to have more foam cells, those macrophages packed with lipids.
Key players in plaque buildup.
Definitely. And larger lipid-rich necrotic cores compared to coronary and especially femoral plaques.
So potentially more active or lipid-driven inflammation there.
It looks that way.
Yeah.
Plus, intraplaque hemorrhage, bleeding within the plaque, seems more common in carotids than femorals.
Interesting. But what about stability features like the cap and calcification?
Carotid plaques often have thicker fibrous caps and more calcification than coronary or aortic ones,
Yeah.
but maybe not more than femoral plaques.
Oh, okay. And the review makes a point about carotid calcification, right? That it's not always a clear predictor of stroke risk.
Exactly. It's not straightforward. It might depend on, the type of calcium, the pattern micro versus macro calcifications, maybe even influenced by things like microRNAs.
So just seeing calcium on an image doesn't tell the whole story for carotid risk.
It seems not. It really challenges that simple calcium unstable plaque idea, at least universally.
What about the vasa velorum, those tiny vessels feeding the artery wall?
They're most dense in the coronaries. The review mentions their potential role in coronary, carotid, and aortic atherosclerosis, maybe less so in femoral. Mouse studies hint at more vessel growth, angiogenesis, in carotid arteries of older atherosclerotic mice, but
Translating mouse studies is always tricky.
it is. We need more human data there.
Okay, shifting down to the femoral arteries again, different microRNA profiles.
Yes, the review notes higher expression of certain microRNAs like miR27A5P compared to the abdominal, aorta, or carotids.
And potentially different roles for things like sugar receptors, more important in coronary carotids.
That's another intriguing point raised. It suggests metabolic factors might play varied roles depending on the location.
And physically, femoral plaques are distinct how?
They tend to be the most fibrous, really dense,
Mm-hmm.
and they have the highest degree of calcification, often in these sort of sheet-like or nodular forms, even bone-like tissue, osteoid metaplasia.
Which is interesting because heavy calcification elsewhere, like the coronaries or aortic arch, is often linked to worse outcomes.
Right. So again, it's maybe not just if there's calcium, but how it's organized and what type it is. The pattern seems key.
So we're seeing this pattern. Carotid plaques may be more lipid-rich and hemorrhagic, femoral plaques more fibrous and heavily calcified. Why?
The review floats a few ideas. Maybe it relates to the artery type, elastic versus muscular, or perhaps even the developmental origin of the smooth muscle cells in the wall.
Ah, the origin story of the cells themselves.
Yeah. There was this fascinating dog study mentioned where they transplanted aortic segments. It suggested the artery segment itself has an inherent susceptibility. It's not purely external factors.
That really underlines the local environment idea.
It does. And even though there's some conflicting data on when lesions first appear, depending on how you look.
Autopsy versus ultrasound, for instance.
Right. The fact remains that we see higher rates of instant restenosis in femoral arteries after we put a stent in.
Despite them being larger diameter vessels.
Yeah. Which probably points to local factors like lower, more variable blood flow shear stress playing a big role in how they heal or fail to heal well after an intervention.
And the mechanical properties differ too, don't they? Arteries get less stiff further from the heart.
They do. And while some studies link carotid disease to underlying coronary disease and femoral disease to subclinical CAD,
the big picture is still one of pronounced heterogeneity. Carotid inflammation looks different from femoral calcification, but the why is still murky.
which leads us nicely into hemodynamics, the forces of blood flow.
And how the endothelial cells lining the vessels respond.
Exactly. These cells are constantly sensing shear stress. Stable, smooth flow, high shear is generally good, atheroprotective.
Whereas disturbed flow, like at branches or curves, with low or changing shear stress.
That's where trouble starts. It promotes atherogenic responses in those endothelial cells.
And shear stress isn't the same everywhere, is it?
Not at all. The review notes it's generally lowest in the femoral arteries, intermediate in the carotids, and highest in the coronaries.
Plus, the timing of blood flow is different. Femoral and carotids get flow mostly during systole,
Heart contraction.
while coronaries fill mainly during diastole when the heart relaxes.
That difference in the pattern and timing of mechanical force could absolutely trigger different endothelial responses.
And we're starting to see this with single-cell sequencing, right? Different endothelial phenotypes.
We are. The technology is revealing differences across beds, but the review rightly points out we still need more detailed work, specifically comparing carotid, femoral, and coronary endothelium in response to their unique flow patterns.
Okay, let's talk about those vascular smooth muscle cells, VSMCs, again. Their origin seems really important.
Hugely important, potentially. The review highlights they come from multiple different sources during embryonic development.
Like, cells in the ascending aorta come from the neural crest?
While descending aorta cells come from Semitic mesoderm, abdominal aorta and femoral from splanchnic mesoderm, coronaries from the proepicardium. Different starting materials, basically.
It's amazing to think that where a cell came from, like, weeks into gestation could influence its behavior in disease decades later.
It is. And there's some initial evidence. Thoracic aorta VSMCs seem different genetically and less inflammatory than aortic arch VSMCs from the neural crest. Hints of these regional signatures.
Differences in signaling pathways, too, like that P27-KIP1 protein.
Yeah, suggesting aortic arch cells might be more prone to proliferate and migrate compared to femoral cells.
And calcification? Does origin track with that?
It's complicated. Aortic arch cells, neural crest, calcify earlier than descending aorta cells, Semitic.
Yeah.
But then the abdominal aorta, splanchnic, is less prone to calcify.
While the femoral artery, also from splanchnic mesoderm, is the most calcified.
Exactly. So embryonic origin is likely part of the story for calcification, but probably not the whole story. Other local factors must be playing a major role.
Like maybe different signaling pathways, like TGF being more active in femoral cells?
That's one possibility mentioned. Femoral SMCs do show distinct gene expression patterns, but overall, as the review stresses, we need more systematic comparisons in humans linking origin to function and disease across all these beds.
Got it. Okay, let's switch gears to the immune cells, macrophages. Always central to atherosclerosis.
Absolutely. They originate from monocytes, infiltrate the vessel wall, and are a major part of the lesion.
And how they get recruited might differ between mice and humans because of the vasorum density.
That's the point raised, yes. And once inside, macrophages aren't monolithic. They exist on a spectrum from pro-inflammatory to anti-inflammatory or resolving phenotypes.
And the balance differs between arteries.
Clearly. The inflammatory status varies significantly. Carotid lesions generally show a higher macrophage burden overall.
You can see this on imaging too, right? Like PE scans.
Yes, with 18 FFDG uptake. And studies using single-cell analysis and flow cytometry show carotid plaques are enriched in pro-inflammatory types, like those foamy IL-1-producing macrophages and CCR2 plus myeloid cells.
More aggressive immune cells.
Seems so. More classical monocytes and also higher proportions of memory and cytotoxic T cells in carotids.
And femoral plaques, what's the picture there?
Quite different. More macrophages with anti-inflammatory markers like TREM2 plus and LYVE1 plus, and strikingly fewer of those pro-inflammatory IL-1 plus macrophages and CCR2 plus cells.
So a less inflamed environment overall.
It appears that way. More B cells, too, interestingly, with a balance between subtypes. It suggests a more homeostatic or resolved inflammatory phenotype in femoral plaques compared to the actively pro-inflammatory carotid environment.
Which fits with clinical observations, doesn't it? Femoral plaques generally being less prone to rupture.
Exactly. The immune profile seems to align well with the clinical behavior.
What about the layers outside the plaque, the adventitia and the fat around the vessels, the PVT?
Regional differences there, too. Coronary PV8, for instance, tends to be pro-inflammatory, churning out cytokines like TNF and IL-6 that likely promote coronary atherosclerosis.
But aortic PV8 might be different, maybe even protective.
There's some evidence for that, possibly involving brown fat characteristics and anti-inflammatory signals like IL-10. But then the PV8 around mesenteric, carotid, and femoral arteries seems more like white fat, producing pro-inflammatory factors that could drive local plaque growth and calcification.
So even the surrounding tissue environment varies significantly.
It does. And that includes nerve fibers and lymphatic vessels within the adventitia. They also show bed-specific features which could impact immunity and drainage differently.
Fascinating. Let's touch on biomarkers briefly. Can we predict site-specific issues from blood tests yet?
Not really reliably, no. Our current risk scores don't usually factor in specific inflammatory markers, while some blood markers like certain miRNAs or neutrophil counts show associations that might differ by vascular bed.
And that recent finding about clonal hematopoiesis and femoral risk is interesting.
Very interesting, yes. But we're not yet at the point of having a blood test tell us this patient is specifically high risk for a carotid event versus a femoral event based on inflammation.
Okay. And single-cell sequencing. That's really advancing the field, isn't it?
Massively. It's given us an unprecedented look at all the different cell subtypes, leukocytes, endothelial cells, VSMCs within the plaques.
Mostly from carotid plaques initially, because they're easier to get.
Right, from endarterectomy samples. But studies are emerging from coronary and other sites too, though comparing can be complex.
But these studies are confirming the patterns we've discussed.
Largely, yes. Comparing carotid and femoral leukocytes, for example, clearly shows the enrichment of pro-inflammatory macrophages and T cells in carotids versus more anti-inflammatory macrophages and B cells in femorals.
So it reinforces that idea of a more homeostatic inflammation in the leg versus pro-inflammatory in the neck.
Exactly. Consistent with the clinical picture. But we still need more studies, especially using spatial techniques that show where cells are within the plaque to fully get the mechanistic details.
All right, let's try and summarize the big picture from this deep dive into that European Heart Journal review.
The core message, I think, is that atherosclerosis is definitely not the same disease everywhere in the body.
It's incredibly heterogeneous. The inflammation, the cells involved, the local environment, it all varies significantly depending on the specific artery.
And the real aha moment is realizing just how deep these differences run right back to the embryonic origin of the cells, combined with local hemodynamics, distinct immune profiles. Understanding this specificity is crucial.
Absolutely crucial if we want to develop better, more targeted ways to diagnose and treat it. Remember to subscribe to Evidence-Based Cardiology Talks on Spotify and YouTube for more discussions like this, all curated under the guidance of Dr. Caroli at drcaroli.com.